Usually when we talk about a major medical diagnosis, there's this underlying expectation of precision.
Right, like it should be black and white.
Exactly. It feels like engineering almost. Like if a patient breaks their femur, you get an x-ray, it shows that jagged white fracture, and the orthopedic surgeon just points to the screen and says, well, there's the problem.
Yeah, it's highly visible, neatly categorized.
And frankly, it's comforting in its certainty,
Yeah.
But then you pivot into the world of emergency cardiology, and suddenly that comforting certainty just completely vanishes.
Oh, it's gone. You are operating in a really, really murky diagnostic landscape at that point.
Right, because think about it. A patient comes into the emergency room, they're clutching their chest, sweating, they're struggling to breathe. On paper, it looks exactly like a massive life-ending heart attack.
Which is terrifying for everyone involved.
Totally. But what if it's not a heart attack? What if it's actually like a bizarre delayed reaction to a common cold they caught at the grocery store last month?
That specific scenario right there is the definition of diagnostic muddy waters. And the stakes literally couldn't be higher for you as the doctor.
Because treating a viral reaction like a major heart attack?
Or worse, brushing off an actual heart attack as just a viral reaction.
Yeah, that has catastrophic consequences for the person sitting right in front of you, which is exactly why we are taking this deep dive today.
I'm really excited for this one.
Thank you. We are exploring the heart's protective shield today. We've got this incredibly comprehensive stack of expert medical review notes from Dr. Asifullah.
And these are completely updated for the 2025-2026 ESC and AHA guidelines, right?
Yes, exactly. All the latest data. So our mission today is to take this highly technical, top-tier board prep material covering acute pericarditis and translate it into a clear, fascinating exploration for you.
It's basically an exclusive peek into how top-tier physicians are trained to think on their feet.
Yeah, we're going to look at how they hunt for those microscopic clues that differentiate benign chest pain from a massive myocardial infarction. And we'll also uncover why the most intuitive treatments are sometimes the most dangerous ones.
And I think it's important to mention that while we are dealing with very specialized medical criteria here, it actually provides a profoundly relatable look at how the human body responds to inflammation.
Oh, for sure.
It really serves as a masterclass in how interconnected and sometimes how overly aggressive our own internal alarm systems really are.
So before we can understand the pain itself, we really need to establish the anatomy for everyone. We're talking about the pericardium,
right?
Which essentially acts like a tight layer of shrink wrap around the heart muscle.
That shrink wrap analogy is visually perfect, honestly. Structurally, it's a double-layered sac.
Okay, double layer.
Yeah, and between those two layers, you have a really tiny amount of lubricating fluid. And this fluid is critical, because your heart beats roughly 100,000 times a day.
Wow, 100,000.
Yeah, so without that lubrication, the heart muscle would essentially rub itself raw against your lungs and your ribs.
Ouch, that sounds awful.
It would be. But when that protective sac gets inflamed, which is what the word pericarditis literally means, inflammation of the pericardium, the physics of your chest cavity, completely change.
Because it's swollen now, right?
Exactly. That flexible shrink wrap becomes rigid, swollen, and just severely irritated.
Creating this intense friction every single time the pump squeezes. It's wild to think about. And to classify this clinically, the notes say the timeline is everything, right?
Oh, absolutely. The timeline dictates the whole approach.
So they classify acute pericarditis as inflammation lasting less than 4 to 6 weeks. But if that, that dragging frictional pain continues for 4 to 12 weeks, it graduates to being called incessant.
Right. It just won't quit.
Yeah. And then past 3 months, it's officially labeled chronic.
But the category that really stood out to me in the notes is recurrent.
Ah, yeah. Recurrent is the primary adversary here, because that means the patient is totally symptom-free for 4 to 6 weeks, they think they're cured, and then out of nowhere, the chest pain just comes roaring back.
And if we connect this to the bigger picture, recurrence is a massive issue. To give you some context on how often doctors actually see this in the real world, acute pericarditis accounts for roughly 5% of all emergency department chest pain presentations that are not heart attacks.
Wait, 5%? That is a massive chunk of ER visits for chest pain.
It really is. And it's significantly more common in men than women, by the way.
But wait, if this is often just a benign, self-limited reaction, like you said, why on earth is it coming back weeks or months later in so many people? Like, are doctors just failing to cure it the first time?
Well, it's a really frustrating puzzle for doctors. The initial prognosis is usually excellent, right? It's generally benign. But 15 to 30% of people will suffer a recurrence after their first episode.
Up to 30%. That's huge.
Yeah. And it gets worse. If you have a second episode, your risk of a third episode skyrockets to 50%.
Oh, wow. So it's like a coin flip at that point.
Basically, yeah. And you aren't necessarily failing to cure the initial trigger. It's more that the patient's immune system gets stuck in this nasty feedback loop. The inflammation becomes its own self-sustaining fire even after the initial spark is gone.
Okay, so let's talk about that spark. What lights the fire? If someone finds themselves in that 5% in the ER, what actually caused their heart's envelope to suddenly swell up in the first place?
So in developed nations, over 80% of these cases are classified as viral or idiopathic.
Idiopathic being the classic medical term for we have no idea.
Pretty much. In clinical practice, idiopathic is often just a polite way of saying, well, we know it's probably a virus, but your immune system cleared it before we could actually identify which one.
Makes sense. So what are the usual suspects if they do catch it?
The standard culprits are exactly what you'd expect. Coxsackie viruses, influenza, and of course, recently, COVID-19.
Right. I mean, we certainly saw a major shift in the conversation around heart inflammation during the pandemic, not just from the virus itself, but also, related to the mRNA vaccines, though I know those instances were heavily scrutinized in the media.
Yeah, and the updated guidelines do address that directly. mRNA vaccines are recognized as a very rare trigger, primarily in young males.
Right, very rare.
Exactly. And the data clearly shows that these specific vaccine-related cases typically present very mildly. They respond exceptionally well to standard short-term therapy.
Okay, good to know.
But jumping back to the broader picture, viruses are just the beginning. The medical community actually uses this great mnemonic pericardium to track all the other potential triggers.
I love a good board prep mnemonic.
Yeah.
Break down the high-yield parts of that for us. What else is irritating this sac?
Well, a really critical one is the P. That stands for post-MI, meaning after a myocardial infarction or a heart attack.
Okay, so a heart attack can cause pericarditis.
Yeah, because a major heart attack physically damages the heart muscle. And that necrotic dying tissue can spark intense inflammation in the sac surrounding it. This can happen early on or even weeks later in something called Dressler syndrome.
Wow. Okay, what else is in the mnemonic?
The E stands for end-stage kidney disease. This is where the kidneys fail to filter out uremic toxins.
And those toxins just end up in the blood.
Right, and they literally bathe and irritate the pericardium. Then you also have A for autoimmune diseases, things like lupus or rheumatoid arthritis. C is for cancer, and R is for radiation therapy to the chest.
So the triggers are just vastly different. I mean, you got a lingering cold on one end and a kidney failure on the other.
Exactly.
But regardless of the spark, the sac is now inflamed. So for you, the patient sitting in the ER, what is the specific physical sensation? Because if I'm the physician trying to rule out a blocked artery, a heart attack, I need to know exactly how this specific pain behaves.
Well, the hallmark presentation is sharp pleuritic retrosternal chest pain.
Okay, medical words. Let's break those down. Pleuritic means?
Pleuritic means the pain spikes sharply when you take a deep breath or when you cough.
Because the expanding lungs are physically pressing against that inflamed sac.
You got it. And retrosternal just places the pain directly behind the breastbone.
But the defining clue here, the thing that really separates this from a heart attack, which I found fascinating in Dr. Cifala's notes, is how the pain responds to gravity.
Yes, the postural changes.
Right. The pain gets worse when the patient lies flat, and it's uniquely better when they sit up and lean forward. If you think about the physics of the chest cavity, right, leaning forward literally pulls the heavy beating heart away from the spine and the posterior chest wall.
Taking the pressure off.
Yeah. Relieving the pressure on that inflamed tissue. It's so mechanical.
And that mechanical reality is your best initial diagnostic tool as a doctor. Because a blocked coronary artery doesn't care what posture you're in.
Right. A heart attack is a heart attack.
Exactly. The heart muscle is starving for oxygen, whether you are standing on your head or lying in bed. So when the pain changes strongly based on posture, it points to mechanical irritation. Like having a blister on your heel, it only hurts when the shoe presses against it.
That blister analogy is perfect. That makes intuitive sense. Yeah. But then the clinical notes list dry cough and hiccups as associated symptoms.
Yeah, the hiccups are a fun quirk.
The cough, I understand. I mean, the lungs are right there. But hiccups, how does an inflamed heart envelope cause a spasm in your diaphragm?
What's fascinating here is that it all comes down to anatomical routing. You have this thing called the phrenic nerve. It's essentially the electrical wire that provides the sole motor control for your diaphragm.
The breathing muscle.
Right. And when the diaphragm is irritated, it spasms, which is a hiccup. Now, that specific phrenic nerve runs right down the outside of the pericardial sac.
Oh, wow. Right next to it.
Literally touching it. So when the sac swells up, it chafes directly against that phrenic nerve.
So the heart is literally triggering a misfire in the diaphragm. That is incredible.
It is. You can also see patients presenting with dysphagia, which is difficulty swallowing.
Wait, how does that work? Does it press on the throat?
Close. It presses on the esophagus. If the sac fills with enough inflammatory fluid, it actually expands backward. And because the chest is so packed, it physically compresses the esophagus.
It's just a brilliant example of how crowded the chest cavity really is in there. Like one swollen structure just causes this massive domino effect.
Exactly.
And the physician isn't just relying on the patient's description of all this, right? They are also listening for a very specific acoustic signature. The pericardial friction rub.
Oh, the friction rub. That is the most specific physical exam finding possible for this. It sounds incredibly distinct. It's the scratchy, high-pitched noise, almost like leather rubbing together or footsteps crunching on fresh snow.
Footsteps on snow, that's a great way to describe it.
Yeah, and crucially, it has 3 separate components that match the mechanical movements of the heart.
Okay, to clarify those mechanics for the listener, you have atrial systole, ventricular systole, and early diastole.
Right.
Basically, atrial systole is the little primer squeeze from the top chambers of the heart. Ventricular systole is the massive, forceful pump from the bottom chambers. And diastole is the relaxation and filling phase.
Beautifully explained.
Thanks. So the doctor is actually hearing this inflamed sac grind against the surrounding tissue during all 3 of those distinct mechanical movements.
Precisely. It's a 3-part scratch. And if a physician hears that specific 3-component sound through their stethoscope, it almost guarantees the diagnosis.
But I'm guessing in modern medicine, we don't gamble solely on acoustics, right?
Definitely not. Because if you're wrong, like we said earlier, the patient might be actively dying from a myocardial infarction.
Right. We need an objective lie detector. Which brings us to the electrical footprints.
Right, the ECG. So the European Society of Cardiology established strict diagnostic criteria for this. And they use the pain mnemonic to remember it.
Pain, P-A-I-N. What does it stand for?
To formally diagnose acute pericarditis, a patient needs 2 out of these 4 criteria. P is for typical pain. A is for auscultation of the friction rub we just talked about.
Right.
I is for typical eye ECG changes. And N is for a new or worsening pericardial effusion, which just means fluid buildup around the heart.
Let's focus on that the ECG changes, because that's where the detective work gets really sophisticated. An ECG tracks the electrical wave moving through the heart muscle, right?
Right.
So in a STEMI, a massive heart attack, an artery is blocked, meaning one specific region of the heart is dying.
And because that damage is localized, the electrical footprint on the ECG is localized.
Makes sense.
On an ECG, a STEMI creates a regional ST segment elevation. The ST segment basically represents the brief pause between the heart contracting and resetting itself.
Okay.
When a localized patch of muscle is dying, it throws off that electrical reset, and it pushes the line upward into this convex shape. Visually, it resembles a sad face, or honestly, a tombstone.
A localized roadblock creates a localized sad face. Got it. But pericarditis isn't a localized blockage.
Exactly.
The entire outer envelope of the heart is on fire all at once.
Exactly the contrast. Because the irritation is diffuse, it's everywhere, and it's superficial, the ECG shows ST elevation across almost all the electrical leads, not just one localized spot.
And what shape is it?
Instead of a convex sad face, the line dips and rises in a concave shape. It looks like a smiley face.
Wow, so a heart attack is a sad face and pericarditis is a smiley face.
Roughly speaking, yes. You also frequently see a depression in the PR segment, which is the part that represents the electrical signal moving from the top to the bottom chambers.
The notes for the 2025-2026 updates also emphasize this highly specific electrical marker called spottic sign.
Oh, spottic sign is a classic board question.
What exactly are doctors looking for there?
It's a downsloping T-key segment on the ECG.
TP?
Yeah, the TP segment is supposed to be the baseline electrical silence right between heartbeats. It should be totally flat. But if that baseline isn't flat, and it instead slopes downward, it is highly suggestive of acute pericarditis.
So it's just this subtle downward tilt?
Yeah, it's one of those subtle, highly tested electrical footprints that really separates expert diagnosticians from everyone else.
Okay, so that covers the I and the pain criteria. Let's address the N, new effusion. The data suggests roughly 60% of these patients develop an effusion.
Right.
Which means their heart is suddenly swimming in a pool of extra fluid. My immediate thought is, how does a muscle keep expanding and pumping blood if it's trapped in a water balloon? At what point does it just start drowning in there?
Well, it's a critical mechanical threshold, actually. The human heart is an incredibly powerful muscle. It can easily pump against a small amount of extra fluid, and the vast majority of these effusions are small.
Okay, but how do they know it's small?
That's the catch. Because we can't see through the chest wall to know exactly how much fluid is in there, the guidelines mandate an echocardiogram, basically an ultrasound of the heart for every single suspected case.
Ah, so they're visually measuring the volume of the fluid pool in real time.
Yes, absolutely. And they pair that visual data with blood work, specifically looking at troponin levels.
Troponin. We hear about that all the time with heart attacks.
Exactly. Troponin is a structural protein inside the heart muscle cells. It only enters your bloodstream if the heart muscle cells are physically dying and breaking open.
Right. So in standard pericarditis, because it's just the sac on the outside that's inflamed and not the muscle itself, the troponin level should be relatively normal, right?
Typically, yes. Normal or maybe just mildly elevated from that superficial irritation rubbing on the muscle.
But what if it's really high?
If the troponin levels are massively spiked, it indicates a diagnosis of myopericarditis.
Myo meaning muscle.
Exactly. That means the inflammatory fire has burned deep into the actual myocardium, the pumping muscle itself. That severely impacts the heart's ability to function, and it completely changes the patient's risk profile.
That sounds dangerous. Do they track anything else in the blood?
Yes, physicians also monitor CRP, or C-reactive protein. It's a generalized marker of inflammation in the blood. They track the CRP weekly to ensure the cellular fire is actually shrinking over time.
Okay, so assuming the troponin is normal, the ECG shows the diffuse smiley face, we hear the friction rub, and we've officially confirmed the diagnosis. Now we arrive at the treatment phase.
The fun part.
Well, this is where the medical strategy seems to completely contradict itself to me.
How so?
We are dealing with severe chest pain and inflammation, right? But the first-line treatment is a heavy combination of NSAIDs and colchicine. Now, NSAIDs mean non-steroidal anti-inflammatory drugs. We are essentially throwing massive amounts of over-the-counter ibuprofen at a serious heart condition.
Well, the dosages are far, far beyond the typical over-the-counter realm. We are talking about 600 to 800 milligrams of ibuprofen every 8 hours, around the clock.
Oh my God.
Yeah, for 1 to 2 weeks straight, slowly tapering off based on those weekly CRP blood levels we mentioned.
That much ibuprofen will absolutely shred your stomach lining.
It will, which is why it's almost always paired with a gastroprotective medication.
Okay, but what if the patient falls into that P category of our mnemonic from earlier? What if their pericarditis was sparked by a recent heart attack? Can they still take all that ibuprofen?
That is the one major exception. High-dose ibuprofen can actually interfere with the healing of the damaged heart muscle, and it can mess with the antiplatelet drugs that are used right after a heart attack.
So what do they use instead?
In those specific post-MI cases, high-dose aspirin becomes the required NSAI.
Okay, got it. But the NSAID is only half the strategy. You also add colchicine, which is a fascinating drug to me. It's derived from the autumn crocus plant, right?
It is, yeah.
And it's been used for centuries to treat gout. So how does a gout medication stop heart inflammation?
Colchicine operates on a deep cellular level. It binds to proteins inside your white blood cells and inhibits microtubule formation.
In English, please.
In simpler terms, it paralyzes the inflammatory cells. They physically cannot travel to the pericardial sac to dump their inflammatory chemicals.
Oh, wow. It just stops them in their tracks.
Exactly. And adding colchicine to the NSAID regimen is basically non-negotiable for most patients because the clinical trials prove it reduces the rate of recurrence by about 50%.
Wow. Cutting the chance of a relapse in half is monumental.
It really is.
But the guidelines are intensely specific about how this colchicine is administered. The notes say you have to dose it based on the patient's body weight, and you absolutely cannot use a, quote, loading dose.
Right. And the loading dose concept is super common in medicine, It's when you give a massive initial dose to rapidly saturate the body and jumpstart the healing process.
Like with antibiotics sometimes.
Exactly. But studies on colchicine in pericarditis prove that a loading dose does not heal the heart any faster. It just drastically increases the toxicity.
What kind of toxicity?
Patients end up with severe gastrointestinal side effects, like debilitating diarrhea.
Yikes. No one wants to deal with severe gastrointestinal distress while it literally hurts to breathe.
Exactly. So the guidelines explicitly state, do not use a loading dose.
Just slow and steady. But here is the biggest strategic trap in the entire protocol. I want you to explain this. We are fighting an inflammatory fire, right?
Right.
Steroids, like prednisone, are famously the most powerful anti-inflammatories on the planet. Yet, Dr. Acifalo's notes emphasize the steroid paradox. Using steroids early is considered a massive mistake. Why wouldn't we just use the biggest hammer in the toolbox to smash this inflammation?
Because that massive hammer doesn't actually fix the underlying cellular irritation. It just forcefully suppresses the patient's entire immune system. The immediate pain relief is dramatic, sure. The patient feels great within a day, but the data is unequivocal. Using corticosteroids as a first-line therapy, especially at higher doses, like over 0.5 milligrams per kilogram per day, virtually guarantees that the disease will return with a vengeance the second you taper the drug off.
So you win the battle in 3 days, but you completely lose the war.
Exactly. The immune system just rebounds and attacks the heart sac even harder than before.
So you're just kicking the can down the road.
Yeah, and artificially creating a recurrent refractory case that is a nightmare to treat. Corticosteroids must be avoided unless there is a highly specific contraindication to NSAIDs.
Like what?
Like a pregnant patient or a patient with severe kidney failure or someone whose pericarditis is driven by an underlying systemic autoimmune disease where they're already required to take steroids anyway.
Makes sense. So the standard patient gets high-dose NSAIDs, weight-based colchicine, no steroids, and strict instructions to follow up. But some patients don't get sent home, do they?
No, definitely not.
The guidelines outline absolute red flags for hospital admission using the mnemonic FAST TBIM. Let's dig into the why behind these flags. F is a fever over 38 degrees Celsius. I assume that suggests a severe infection.
Right, could be bacterial, which changes everything.
A is if the patient is on oral anticoagulants, so blood thinners. I imagine bleeding into a closed sac around the heart is a fast track to disaster.
It is a highly, highly lethal combination.
Yeah. Then the S stands for a subacute onset, meaning the pain has been slowly brewing over weeks rather than hitting suddenly.
Right. Subacute presentations often point to more dangerous underlying causes, things like tuberculosis or even hidden malignancies like cancer.
That's scary. And the T stands for tamponade. This loops back to my question earlier about the heart drowning in fluid. When does a simple safe effusion become cardiac tamponade?
It becomes tamponade when the pressure inside the pericardial sac actually exceeds the pressure inside the heart chambers.
Oh.
See, the right side of the heart, the right atrium and right ventricle, operates at a much lower pressure than the thick-walled left side. If the inflammatory fluid builds up too rapidly, the shrink wrap can't stretch fast enough.
So the pressure spikes.
Exactly. The pressure spikes, and the right side of the heart literally collapses inward. It physically cannot expand to fill with blood.
And if the pump can't fill, the pump can't push.
Right. The entire circulatory system just crashes. It is an absolute drop-everything medical emergency.
How do they spot that in the ER?
Clinicians look for the Beck triad to identify it quickly. It's 3 things. Hypotension, meaning dangerously low blood pressure because the pump is failing.
Okay.
Elevated jugular venous pressure, meaning the veins in the neck are literally bulging out because the blood is backing up into the head.
Whoa.
And finally, muffled heart sounds because the physician is trying to listen to the heart through a thick wall of pressurized fluid.
What is the fix for that? You can't just give them a pill, right?
No, absolutely not. You need immediate physical decompression. The procedure is called an urgent pericardiocentesis.
Which sounds intense.
It is. A physician inserts a needle directly through the chest wall into that pericardial sac and manually drains the fluid out with a syringe to relieve the pressure and let the heart expand again.
That is incredibly intense. Needles straight to the heart. Okay, to finish out the FAST TBIM admission criteria real quick. The second T is suspected TB or bacterial cause, which requires specialized antibiotics.
Right.
B is a big effusion, classified as a fluid pocket larger than 20 milliliters on an echo. I is for immunosuppressed patients whose bodies can't fight off the trigger. And M is myocardial involvement, which we discussed with the elevated troponin, or NSA failure after a week of treatment.
Perfect summary. And if a patient has any single one of those, it triggers an automatic hospital admission.
But even for the uncomplicated patients who are allowed to recover at home, there is one final, non-negotiable rule in the notes. Absolute activity restriction.
Yeah.
If the patient is a competitive athlete, they are banned from sports for a minimum of 3 months.
That's right.
3 entire months.
Yeah.
Just for inflammation.
Yes, and even for non-athletes, they must avoid all strenuous physical activity until their symptoms have completely vanished, their CRP inflammatory markers are back to absolute baseline, and their ECG has completely normalized.
Because if they don't.
If a patient feels better after 2 weeks and decides, to go for a heavy run, the increased heart rate and that mechanical friction we talked about will almost certainly reignite the fire and trigger a recurrence.
Which brings us back to the nightmare scenario. What happens to the 15 to 30% of people who follow all the rules? They take their massive NSAID doses, they take the colchicine, they rest for months, and the chest pain still comes back.
This is where the 2025-2026 guidelines push into the absolute cutting edge of immunology. For these refractory cases, the patients who just keep relapsing, or worse, have become dependent on steroids just to function day to day. Modern medicine utilizes targeted biologic therapies.
Like what?
Specifically, interleukin-1 inhibitors. The big one is anakinra.
How does blocking interleukin-1 fundamentally change the equation for these patients?
Well, interleukin-1 is a highly specific inflammatory cytokine. Think of it as a specialized chemical alarm bell that the immune system uses to call in inflammatory forces.
Okay, I'm with you.
In recurrent pericarditis, this specific alarm bell gets jammed in the on position. The body is essentially attacking itself over a threat that no longer exists.
It's just ringing and ringing.
Exactly. So anakinra is a molecule that physically blocks the receptor for that alarm.
So the cytokine is still screaming, but the immune cells literally can't hear it anymore.
That's the beauty of it. It shuts down the specific inflammatory pathway responsible for the pericarditis, but without indiscriminately crashing the rest of the immune system the way steroids do.
That's amazing.
It really is. It has completely revolutionized the management of recurrent disease, finally allowing doctors to break that cycle of inflammation.
It is just staggering to think about the spectrum of care we've just covered today. I mean, to summarize this whole journey for you, acute pericarditis is a painful inflammation of the heart's protective shrink wrap.
A perfect way to visualize it.
And the diagnosis relies on these clever mechanical clues like pain that vanishes when you sit up and lean forward, and electrical footprints, specifically that diffuse smiley face ST elevation, and the subtle Spodek sign on the ECG.
And then the treatment is just an exercise in extreme restraint.
Right. Attacking the fire with targeted colchicine and heavy NSAIDs while fiercely avoiding the seductive trap of early steroids.
All while remaining hypervigilant for the catastrophic physical mechanics of cardiac tamponade.
It requires a clinician to simultaneously act as a detective ruling out a heart attack, an immunologist blocking cellular signals, and a tactician enforcing a months-long recovery.
It really is a masterclass in how delicately balanced our internal systems are.
It totally is. Which, honestly, leaves us with a fascinating thread to pull on. I mean, if a microscopic virus you fought off weeks ago or a totally routine reflex like a hiccup can be traced back to the swollen protective envelope surrounding your beating heart, it really makes you wonder about the architecture of our own physical awareness.
No, absolutely.
Think about it. How many of our everyday minor physical sensations are actually subtle pings from a complex internal alarm system that we simply haven't learned to translate yet? I mean, if shifting your posture can silence an inflamed heart and a chafed nerve can make your diaphragm spasm, what else is your body trying to tell you right now?